everybody, this is Dr. Reyes-Fournier. We are already at Unit 3, where we're going to be talking about risk assessment and harm reduction. Despite the fact that they sound similar, they're very different. Risk assessment is something that we do every time we see a client, and harm reduction is a form of therapy. If we think about it, harm reduction is very simply what we've been doing with methadone maintenance for the last 40, 50 years of treatment. Even though we know that it's probably best for the individual to stop using the drug altogether, this might not necessarily be the proper treatment for an individual. And in fact, what they're showing in places like Canada and Portugal, that harm reduction actually works a lot better, and you find less cases and dramatically less cases of relapse. It's based on this idea that yes, we would prefer abstinence, but it is better for some individuals to just do harm reduction. This is being done since we started doing methadone and other forms of care where we change the drug of use to something less harmful for the individual. And also it works on the idea that it's a collaborative effort between the therapist and the individual to create a program where the individual starts taking care of themselves. And this isn't just looking at, oh, all drugs are bad, because honestly, all drugs are not bad. But to look at it as a way of they can continue their lives without having to indulge in so many drugs. There is a very wide swath of nurturing involved in harm reduction that you don't see in other therapies. Even things like, if we look at the types of therapies done in treatment, they tend to be a little bit harsh in the sense of, you have people doing confrontations. Even cognitive behavioral therapy can be quite combative, depending on how tightly the individual is holding on to their irrational beliefs. So that is harm reduction. We're going to be talking about that. And let's see, we're going back here. We're going to talk more about risk assessment. Risk assessment is a larger part of what you do on a daily basis as a therapist. You are always looking at the possibility that an individual may hurt themselves or others. The sheer act of using drugs shows that the individual has very little care about their own body and their life for that matter in certain respects. I will be giving you the link here where we talk about the assessment process and the screening process and the idea of constantly doing risk assessment. One of the assessments that we use during intake and screening is the ASAM, which is going to ask questions to give us a better idea of where the individual should be placed in terms of either outpatient, intensive outpatient, medically managed inpatient, or just medically monitored inpatient. For example, things like detox. What is the best way to detox the individual? Well, if they're using opiates or they're very heavy drinking alcoholics, then it's probably best to put them in a medically managed inpatient, because they pose a severe risk to themselves. When you take them off their drug of choice, alcohol or opiates, the possibility of having severe physical reactions are very high. And those severe physical reactions could either kill them or it could lead them to want to hurt themselves. So this is what the ASAM does. We're going to cover that more in treatment in our seminar in treatment. I love that. Okay, so suicide risk assessment is something that we do on the daily with our clients. We're checking in on them. How are you doing today? We are looking for any signs that they might be at risk of hurting themselves. So I will be including all of these with this video so that you can look at what we are doing. We are looking for possibilities of ideation, thinking of committing suicide, planning. Do you have a plan for this? And we're also looking at protective factors. What are the protective factors for people so that people don't hurt themselves? And that's an important thing that we look at, especially when we are conceptualizing the client, like we talked about before. Do they have family? Do they have friends? Do they have something that is important to them, more important to them than anything else? And those are very crucial things when it comes to looking at risk reduction and risk assessment. We have to look at specifically, since we're dealing with co-occurring disorders, the fact that people who suffer from depression, psychosis, or cluster B personality disorders are already at a high risk of hurting themselves. So we'll be going through all of this on Monday during seminar. Have a wonderful week. Any questions? Email me, and we'll talk soon. Thank you.